Hello, everyone, and welcome to the third episode of Oncology Watch. I'm Amr Shafik. I'm professor of clinical oncology at Shams University, Cairo. I'll be your host today. And first, I thank Oncology Me team for arranging this meeting. We are honored to have today Professor Yasser Abd Elkader, professor of clinical oncology, Cairo University, Egypt, and the well-known international expert in lung cancer. Welcome, Professor Yasser.
Welcome. Thank you.
And also we have with us Professor Fabrice Barlesi, Professor of Pulmonology. Oncology needs no introduction. He's a Chief Executive Officer of Gustave Roussy Cancer Center in Grand Paris, France. Welcome, Professor Fabrice.
Thank you for inviting me. It's a great pleasure to share this session with you.
So I think we are ready to start now. So if you have any questions you want to pose, please ask in the comments below and we will answer also in the comments. For almost 30 years, the gold standard of first-line therapy for metastatic non-small cell lung cancer was chemotherapy. Then came the driver mutation and changed the game. And now we have two main categories of non-small cell lung cancer: those with driver mutation who are treated by a multitude of TKIs, and those without, or the other name, the all-wild type. And those go for immunotherapy plus or minus chemotherapy. So in 2023, Professor Fabrice, how would you define all-wild disease? And what are the main mutation to test for, and if it come out negative, in order to go for chemo and or immunotherapy?
It's of course a great question, and these questions is evolving during the time, because I believe that the definition is linked to the number of drugs that can action the mutation or fusions that we know. Then I would define fully wild type non-small cell lung cancer patients, I would say negatively, by defining the patients who are not carrying any mutation that we can action. Then probably these patients, we know that the type of mutation we can identify are EGFR mutation, of course the BRAF mutations. We have also the ALK and ROS1 fusions, but since I would say a few months or years, we also have the RET molecular alteration, the NTRK alteration that could be targetable. And of course, in the middle, we have the HER2 mutation. We know that we have some drugs that could be useful for those patients, especially antibody drug conjugates. And we also know that the KRAS mutated patients are now targetable in the second line setting, but probably very soon in the first line setting. Then I would say for me, I would define the patients that are fully wild type by excluding all the molecular alteration that have potential drug to give to the patients.
Now, Professor Yasser, do you test for PD-L1 expression at the same time? Do you test for PD-L1 expression in the same with the driver mutation? And which assay do you ask for when you ask for a PD-L1 expression testing?
The PD-L1 testing is routinely assessed in our region or in our country by immunohistochemistry, and it is a mandatory or a must. Apart from the immunohistochemistry or apart from assessment for the PD-L1, we have to go to 9 mutations, those 9 tests: EGFR, ALK, ROS1, BRAF, MET, RET, and HER2 new recently introduced, and TRK. So you have to fulfill the data. You have to go to a broadened molecular profiling for your patient, and don't look at the PD-L1 expression, whatever 50, 60, or high or low, except after fulfilling or after knowing the broadened molecular profile of your patient or the molecular profile of your patients. So it is the current practice in our region. We do PD-L1 definitely, and EGFR, at least EGFR, ROS, and ALK, at least.
Okay, and regarding PD-L1 expression, when you send to the lab, do you ask for a specific assay? Example, like 22C3, like
Yes,
SP?
yes.
Yeah.
Yes, we have to specify the methods of assay if you are willing or you are willing to give a specific drug, because it's a specific drug, or each drug or each immunotherapeutic agent has got the approved methods of assay. So we have to specify. Recently, we are specifying actually the methods of assay.
Assuming the full genetic testing might take up to 4 weeks, should we choose to start empirical therapy, Professor Fabrice, and which regimen would we use?
I would say that it's right that when we are talking about tissue testing, it may take up to 4 weeks to have the full results in our hand to take the decision. But we also have some alternatives regarding the molecular testing. The liquid biopsies may be used in the, I would say, initial workup, especially to identify molecular alteration with actionable drugs. Then and we know that the results are coming in approximately 15 days, then we could decrease this turnaround time. And the second point is that we have some molecular alteration that may be identified by immunohistochemistry, especially ALK and ROS1 alteration. And we have some very fast techniques to identify EGFR and BRAF mutation. Then I would say the initial workup, the initial sign that the patient may carry a molecular alteration may come in a lower turnaround time. But to come to your question, if I don't have the results and I want to start, I would say that usually we are following the PD-L1 status assessment, and if the patient has no risk of rapid progression of the disease and the PD-L1 status of more than 50%, we usually treat those patients with PD-1 or PD-L1 inhibitors alone. And in the other cases, we use chemo-IO.
Now we can go back to Professor Yasser. So in an all-wild advanced non-small cell lung cancer, let's look into each scenario separately, Professor Yasser. What if our patient came out negative for PD-L1 with a percentage of less than 1%? What would be your treatment option? And again, it is an all-wild advanced non-small cell lung cancer in a PD-L1 negative.
Definitely, up to this moment, we have no FDA-approved monotherapy for negative or low expressor. So the low expressor or the negative PD-L1 patient should receive combination chemotherapy, and not every combination of chemoimmunotherapy. Because if you look at the data of the EMPOWER-3, EMPOWER with E, EMPOWER-3 is chemo, immune versus chemotherapy. In PD-L1 less than 1%, it is a negative. So you have to specify and to have to know properly the data of the combination. Not every combination should work, but at least you don't give monotherapy in low expressor.
So we have a question for Professor Fabrice, which is actually a common question in Egypt regarding the chemo partners that might be sometimes it's in shortage, and there is an unavailability for pemetrexate examples. So Professor Fabrice, what would be your alternatives in non-squamous patients?
I would say there are two types of response to your question. If we look at the data that we have, clearly the only data that we have to replace pemetrexate are in fact based on taxane combinations. And I would say the most solid data are coming from the trials combining carboplatin and paclitaxel usually with immunotherapy, even in the non-squamous non-small cell lung cancer patients population. If we look at the biological data that we have and some clinical data, we know that there are probably an equivalence across all the regimens that may be combined to immunotherapy. There is no preferred regimen for that. Then I would say there is the most solid data using paclitaxel and immuno, but I may say that you can use whatever type of chemotherapy backbone that is available for your patients if you don't have an access to carboplatin and paclitaxel, or if you don't want to use it because of the some side effects.
And another one question for you, Professor Fabrice. So if you have, like example, a positive PD-L1 patient, do you consider all patients from 1 to 49% the same, and which regimen would you offer?
You know that regarding the PD-L1 expression by standard techniques, we know that there is an inter-observer variability, almost 10%. We also know that we could have some false results in approximately 33% of the patients. Then I would say that globally, I believe that between 1 and 49%, we should treat the patients as we treat patients with PD-L1 negative tumors. Then the combination of chemo-IO is clearly representing the standard of care for those patients. And I'm not considering differently patients with like 45% of PD-L1 expression. And I believe this debate is also probably true even for patients with 50% or more. And we know that the heterogeneity in the PD-L1 expression, the variability in the assessment of the PD-L1 expression have to be taken in consideration when deciding the treatments. But below 50%, there is no doubt that the standard of care is chemo-IO.
Professor Yasser, would you like to comment on this question? Do you treat all patients from 1% positivity for PD-L1 till 49% positivity as the same? Are they the same for you?
No. I have to look at the histology. The histology is mandatory in deciding, in the decision making of combination immunotherapy in low expressor. Let us take an example of the squamous cell histology in the keynote 407. Squamous. You look at the hazard ratio of the progression-free survival is 0.83. Okay, squamous. And if you look at the combination of 9LA checkmate. 9LA, the squamous hazard ratio is 0.43, so it is doubled with the combination of 407. So it acts in the squamous. So anyway, I have to look at the histology in low expressors. Some of the trials or some of the data are positive with the squamous, and some are not. As I have said, look at the 407 and look at the 9LA in squamous cell histology, apart from the PD-L1 expression. So both are the low expressor, and there is a huge difference in the squamous cell histology in this combination. And again, don't forget that not every combination acts in the low expressor. One of the famous example in the Empower with I mean the semiplimab, the Empower 3, lung 3, that does not act in low expressor.
Great. So again, Professor Yasser, so if your patient is frail, for example, severe weight loss, poor performance status, mainly because of cancer-related problems rather than comorbidities, would you change your approach with immunotherapy in any consideration?
Yes, because the data we got from any patient, from any trial, if you look at the hundreds of trials of chemo or chemoimmuno in performance 0 to 1, but the poor performance patients are among the special population. Do you give your patient chemoimmuno or immunotherapy in the elderly, in poor performance? Yes, I can give. We have data on the pembrolizumab for poor performance patients, and you have data on the atezolizumab, the EPSOS trial in the elderly population. So we can give in poor performance patients immunotherapy, but I think in poor performance patients, immunotherapy alone could act, and not in combination because of the performance of your patient. But it works.
So back to Professor Fabrice about the high expressor patients with more than 50%. In which patients can we go for immunotherapy only?
It's really difficult to give you objective data to make this choice because we don't have any clear data. What we know is we have the trial, the Keynote 24, the Keynote 042, and the Empower trial. But we all know from our practice that we have some patients with disease that is progressing very rapidly on immunotherapy alone. If we look at the data, and if you try to compare, taking only the Keynote studies and the non-squamous patients, we know that the response rate is clearly higher for the combination of chemo-IO, more than 60%, compared to IO alone, around 24%. If we look at the progression-free survival, and especially the 1-year progression-free survival rate, it is also better for patients treated with chemo-IO in the field of patients with more than 50% of PD-L1 expression compared to IO alone. Then the elements that I'm taking in consideration when taking the decision are the burden of the disease. Is the disease highly symptomatic or not, and made the treatment regimen help by the response rate and the highest response rate to better control the symptoms? Are there any tumor or metastasis that is at risk in case of early progression? And we can think to brain metastasis, large brain metastasis, large thoracic tumors, etc. And also, I would say the general status of the patients and how the disease and the burden of the disease is influencing this general status. Because unfortunately, we know that, and it was also the case before the era of immunotherapy, but we know that the chance for a patient to receive a second-line treatment in case of a failure of the first-line treatment is of approximately only 60%. Then the problem is that if we miss the good treatment in the first-line setting, then the patients may die before receiving a second-line treatment. And with these type of elements, we take the decision. But I agree that there is no clear objective data that we may use in order to recommend to use either the monotherapy or the combination in case of PD-L1 expression of more than 50%.
And now we have a question for Professor Yasser. So sometimes we have long remissions with disease control for years on first-line immunotherapy, and I emphasize on sometimes. Here we come under the stress of drug toxicity and financial toxicities, which always remains a question: when can we stop? If a patient is in remission for a relatively long time and we are on pressure from some like endocrinal insufficiencies, some financial toxicities. So when is the time factor that we say, okay, maybe I can stop now? Professor Yasser.
Okay, it depends. Apart from the financial toxicity or the immune-related adverse events, let us take the standard of care. Let us look at the standard of care of immunotherapy in either situation or the situation of first line or the situation of subsequent therapy. In first line setting, the standard of care is to give the immunotherapy up to 2 years and more in the responding patient, definitely in the first line setting. In the second line setting or subsequent therapy with immunotherapy, you have to continue till progression or till progressive disease or unacceptable toxicity, or toxicity that may include financial toxicity, but up to 2 years in the first line setting.
That's great. So this question is actually for you, both of you, Professor Yasser and Professor Fabrice. So if we have a female non-smoker metastatic non-small cell lung cancer with high PD-L1 expression, example 80%, with an EGFR mutation classical exon 19. So Professor Yasser, your take about this case would be?
I think you have to follow the standard of care in the classical mutation 19 or 21, and you have to go to, irrespective of the PD-L1 expression, you have to go to the standard of care or a targeted the TKI. And we have to wait. Why? Because if you start and if you are very happy with the high expressor in EGFR mutant patient, we start immunotherapy, then you got the results of the oral TKI, then you shift to oral TKI, you are recording a severe immune-related adverse events, sometimes are life-threatening, so we have to wait. The standard of care, irrespective of the PD-L1 expression, is the oral target therapy in the classical mutation.
Clearly, there is no doubt that the good and the recommended first-line treatment in case of EGFR mutations or other demonstrated molecular alteration that has to be considered as an oncogene addiction is the targeted treatment, both for the response rates, the duration of response, the median progression-free survival, and the overall survival. And clearly, we should start those patients on targeted treatment. And if there are different lines of targeted treatments, they should be treated and use these different lines of treatments. It's important to have in mind because effectively we can have in some patients high PD-L1 expression even in those patients with oncogene-addicted tumors, but this type of expression is not linked and based on the same mechanism as it's the case for the patients without oncogene-addicted tumors. Then it's absolutely mandatory to have, especially if we have never smoker patients, to have the molecular profiling, the full molecular profiling before deciding and starting the treatment.
So if based on Professor Fabrice's comment, I will ask you again, Professor Yasser, in the same setting, if in the same condition with a female, non-smoker, metastatic non-small cell lung cancer with high PD-L1 expressors, more than 50%. However, this time she has an EGFR mutation exon 20, a non-conventional, non-common mutation. Would your answer change if she has an exon 20? Would it change?
Yes, because we got the data and we have to follow the guidelines, we have to follow the standard of care in patient having the cold or the uncommon or the rare mutation. Let us say exon 20, the standard of care is the first line platinum doublet chemotherapy and not targeted therapy, because the oral or the conventional or the oral TKI, the first or second or third generation, did not act in this exon 20. So in exon 20 patient, the first line is still platinum doublet, and we are waiting, definitely eagerly waiting for the results of the two approved drugs in the subsequent therapy, the amivantamab and the mobocertinib in the first line setting, and you have to wait the results in the first line setting of these trials, the Papillon trial and the Exclaim trial, the ECRISA trial, comparing in the first line setting of exon 20 chemotherapy, platinum doublet, which is the standard of care, versus Amiva, or comparing the mobocertinib with chemotherapy in the first line setting in treatment naive patients. But up to this moment, I have to follow the guidelines. The standard of care of patients with exon 20 is platinum doublet chemotherapy, and subsequent therapy is Amiva or mobocertinib.
Okay, great. So coming back to my final question, so this is a question for Professor Yasser and Professor Fabrice. With the approval of the use of checkpoint inhibitors in the neoadjuvant and adjuvant settings of non-metastatic non-small cell lung cancer, what will happen if the patient reached later on the metastatic settings? So
you're right. It's a very good question, and we know that unfortunately, even when receiving adjuvant immunotherapy, we have a large part of our patients who are still relapsing. We don't have a lot of data regarding how we can define primary and secondary resistances in this setting, and what is the activity of, I would say, chemotherapy alone, or the combination of chemo-IO or even IO alone in this setting. Our decision may be based on the definition proposed by the SITC, and a paper was published in 2020. And regarding the patients treated in the neoadjuvant or adjuvant setting, they proposed to consider the 12 weeks of as a cutoff for defining the primary and the secondary resistance. Then, if a patient is relapsing more than 3 months after stopping the adjuvant immunotherapy, then you may reuse adjuvant therapy, considering that it could be a secondary resistance. If they are progressing in a lower delay, then probably those patients are primary resistant to immunotherapy, and there is probably less interest or no interest at all to receive immunotherapy. But these proposals, these guidelines were proposed in order to help to design the next generation of trial that will look at this question specifically. Then it's something that may be in our mind when deciding, but it is not based on objective and scientific data for the moment.
Your comment, Professor Yasser?
It is a very, very difficult question, and the answer will be very difficult. Why? Because you can say that the re-challenge could be an option. The re-challenge is not the re-challenge of cancer ovary. Let us say it is not the same. It is not the same re-challenge with platinum in case of small cell lung cancer. It It is a gray zone, and we have to wait the many trials that are eagerly waiting for the data and the results in IO pre-treated patients. What is meant by IO treated patients? IO in the neoadjuvant setting, IO in the adjuvant setting, IO in the consolidative setting, and the IO in the metastatic setting. I think we have plenty of trials, and I think we have the hope of delaying or omitting the resistance. Up to this moment, we have positive and promising data on the not the rich challenge to continue with immunotherapy and to add one of the pan-TKI inhibitor like cetravatinib plus nivolumab Sapphire trial, and we have got phase 2 positive data from Sapphire cetravatinib plus nivolumab. So I think the answer will be in the next coming years, and I think the answer will be the data of the ongoing trials of Immuno plus X. What is X? These are the trials that may delay the mechanism or they counteract the mechanism of resistance, like the anti-TIM, the anti-LAG, and so on.
That's quite an answer from both professors. I totally understand, and we are actually facing this situation in many disciplines of oncology now, where the advanced treatment are going forward to adjuvant settings and new adjuvant settings in diseases, and we'll wait for the outcomes of studies. However, in this time, we'll have to adapt to what we have, what kind of data we have, and I think it's quite a brain-teasing situation, and I hope this will end up to the benefit of the patients. So at the end, I would like to thank you, Professor Fabrice and Professor Yasser. We really enjoyed the discussion very much, and I hope you all enjoyed it like me. Please, if you have any questions, keep asking, and we'll answer in the chat, and see you later in another episode of Oncology Me Watch, and goodbye.